Hello, and thank you for this opportunity to present on behalf of the National Spasmodic Dysphonia Association on the topic of clinical assessment and treatment of individuals with vocal tremor. My name is Julie Barkmeier-Kraemer. I am a professor of otolaryngology head and neck surgery at the University of Utah. I am trained as a speech-language pathologist and serve as the clinic director for the Utah Voice Disorders Center. I'm also an adjunct faculty in the Department of Communication Sciences and Disorders and am director of the Voice Airway Swallowing Translational Research Lab. My disclosures are listed here related to financial and non-financial disclosures, including the pleasure of serving as a member of the NSDA Scientific Advisory Council. And for this presentation, my objectives are the following. I plan to identify and describe the updated classification tremor criteria applied to vocal tremor and evaluation of speech structures, to describe clinical assessment approaches that help us improve differential diagnosis between those with vocal tremor that is co-occurring with laryngeal dystonia versus those who have vocal tremor for other reasons, and also to summarize primarily a behavioral treatment option for consideration with those with vocal tremor. So the primary goal here is to really address what we feel challenged by clinically, and that is differentially diagnosing individuals who present with voice disorders that can present with overlapping symptomatology. It is not uncommon for individuals who have spasmodic dysphonia, now renamed laryngeal dystonia, to be confused with other individuals who have vocal tremor. And in our history, it was actually a little easier for us to identify that vocal tremor was the cause of a voice problem. But interestingly, in more recent times, due to increased awareness of spasmodic dysphonia or laryngeal dystonia, we now almost overdiagnose laryngeal dystonia and aren't very careful about assessing the vocal tremor. And so that will be my primary thrust here in this talk, is to clarify ways we can be more systematic and help become more precise in our diagnosis. Why do we care? Does it matter with our treatment? It does, as a matter of fact. For those of you who have vocal tremor due to other etiologies besides dystonia, there may be medications that systemically could be tried to help manage your vocal tremor symptoms. Further, being mindful of which musculature is affected can also inform whether Botox treatment, which is commonly used to treat spasmodic dysphonia, is a good option, or whether it may have minimal benefit. Further, what muscles would you target? Optimally, we want to inject Botox into the musculature that's affected, especially in those with tremor. And if you inject musculature that's not affected, it could actually worsen the symptoms. So it matters. It matters to be precise, and it matters to be informed about what your problem is so that you can make good decisions for yourself as a consumer. So let's start with spasmodic dysphonia. This is a focal laryngeal dystonia considered as a hyperkinetic movement disorder that affects one body part. It is characterized by a dystonic, sustained or intermittent muscle contraction that causes abnormal, often repetitive movements or postures, or both, and it worsens during volitional activity like speech. And so we often use that characteristic to describe task specificity. In other words, you go to do something on purpose and you struggle because the muscles don't cooperate. They spasm or create contractions that interfere with the task you're trying to do. Focal laryngeal dystonia is quite rare. It affects 1 per 100,000 dystonia cases. And less than 8% of those with laryngeal dystonia have family members with dystonia. Now, over the years, the name by which we term laryngeal dystonia has also evolved. Early on, we referred to it as spastic dysphonia because it sounded like a spasm that was occurring in the throat. And then we became more cognizant of the fact that it wasn't a constant spasticity, but something that was more variable In some cases, individuals would exhibit an island of normal speech. So that's where the term spasmodic dysphonia came from. And now, in order for us to align our terminology with movement disorder specialty classification, we've recommended that we now progress to using the term laryngeal dystonia to signify the focal structure affected by dystonia, and then subtype it further by saying laryngeal dystonia of the adductor type or abductor type, respiratory type, singing type, and so forth. So laryngeal dystonia of both the adductor and abductor type has fairly been characterized in our literature as having an idiopathic onset, meaning we don't know what causes it. And this typically occurs during midlife ages, between the ages of 30 to 50 years. Women tend to be more often affected than men, depending on the publication. It's somewhere between 60 to 85% being female. And most people report that their symptoms come on quickest during their first year of onset, and then at some point it stabilizes and becomes chronic. These individuals sometimes struggle to be diagnosed because vegetative voice function is perceived as normal, meaning the voice sounds normal in function during laughing, crying, coughing, maybe even yawning. Whispering is non-effortful, and sometimes there are just islands of normalcy in speaking. And so this often makes it difficult to identify the underlying cause being a dystonia versus another kind of diagnosis that we think of as more of a behavioral voice muscle tension dysphonia. So they can sometimes be confused with each other. In addition, we have some subtyping of laryngeal dystonia, and the most common by far of the characteristics are those who present with the adductor type of spasmodic dysphonia or laryngeal dystonia, with a smaller proportion having the abductor type, and even smaller number truly having a mixed presentation of symptomatology. About a third in our literature are described as having a co-occurring vocal tremor. I would venture to guess after I finish my talk today that we could together surmise this may be an overestimation. My guess is as we get more precise in how we assess and classify those who have a vocal tremor that we think may be co-occurring with laryngeal dystonia, we may come to find, in fact, we have been misdiagnosing individuals with laryngeal dystonia and a co-occurring vocal tremor who actually have a more severe presentation of essential tremor affecting their voice or an isolated vocal tremor. But let's talk a little further about that. So tremor is characterized as an involuntary, rhythmic, oscillatory movement of a body part. It is the most common neurologic movement disorder in the world. And the movement disorder specialists have been updating over time how they classify tremor. It is typically classified by the clinical features, often described as phenotypes or signature profiles of those clinical features that tell us how we should classify the tremor. And then also by etiology, the underlying pathophysiology that's causing the tremor. When we describe tremor, there are two primary classification features that we may identify. One is a tremor that is considered action-induced, meaning that muscle has to contract in order for the tremor to occur. This typically occurs either while holding a posture or while moving a structure affected by tremor. And the postural tremor is called postural. Purposeful movement can be further characterized typically as kinetic, but we can also further describe whether it's throughout the course of a movement, at the onset of a movement, at the end of a movement, and so forth. The second feature to classify tremor by is resting tremor. Resting tremor is characterized by the structure that's affected by the tremor only showing tremor when the muscle is or the structure is supported by against gravity. What will happen when you support that structure is the muscle doesn't need to contract any longer, and you start to see a tremor. This is signature of those who have Parkinson's disease and that pill rolling that we see when they rest their hand in their lap, versus somebody who tries to hold a coffee cup with essential tremor, and their hand shakes when they try to hold the posture or hold the coffee cup, or when they're trying to write. Now, tremor has been classified and reclassified over time. We have a recent publication by Bhatia et al. That was put out in 2017 online and formally published in 2018. This updated consensus statement offers greatly improved classification descriptors and guidelines for tremor. And so I'll talk a little bit about that, because it is something that the knowledge in that publication has not necessarily translated to our use in assessment for those who have vocal tremor. So tremor syndrome clinical features in our updated classification require us to identify very specific features from the medical history of the individual, the tremor characteristics based on anatomic distribution of the tremor, conditions under which it is activated, and if possible, to estimate the frequency of oscillation when tremor is observed. Also noting any associated signs, like signs of a systemic illness associated with onset, neurologic signs, or soft neurologic signs. And then recommendation of additional laboratory testing when appropriate, like electrophysiologic testing, structural imaging of the brain and nervous system, receptor imaging, and biomarkers that can be tested from serum and tissues. Those are all considered Axis 1 or clinical features, but there are also a separate framework based on etiology called Axis 2 that are broken out now in the classification of tremor in this new publication. And really the key points to take away from the new updated classification system is the primary features of interest for classifying tremor are really gleaned from our clinical assessment and observation. So the clinical features dominate for our optimal way of characterizing or classifying the tremor. But syndrome Axis 1 mapping can also be utilized to characterize one etiology or multiple etiologies associated with the observation of tremor. And this enables us not to get confused about etiology driving classification. So based on clinical features, here are some predominant classification criteria that will also be relevant to vocal tremor. Those include essential tremor, which now is delineated to mean that individuals are diagnosed with essential tremor when their symptoms are present for a duration of 3 years or more and present with bilateral tremor affecting the upper limbs with or without head tremor or tremor of other locations, and in the absence of dystonia, ataxia, and Parkinsonism. Essential tremor plus is all of that for essential tremor, but also the observation of soft neurologic signs like mild memory impairment or gait issues or subtle body posturing similar to dystonia that need a little more time in order to determine if there is something else going on in addition to the essential tremor. If somebody has all of those indicators of essential tremor, but they are under 3 years of duration, they are called an indeterminate tremor. So they have a way of capturing those individuals, but they want to give enough time for symptoms to be there in order to be firm that there isn't something else evolving in the onset of their disorder. Parkinsonism is characterized by bradykinesia and rigidity. It tends to present with a unilateral or asymmetric resting tremor, typically in the hands. And that resting tremor diminishes when individuals initiate muscle contraction to move their hand. And then finally, dystonic tremor is tremor that is observed in a body part affected by dystonia. And these symptoms can sometimes be altered or reduced through sensory tricks. Sensory tricks are signature of those who have dystonia, and those can be anything from a palpation or tactile stimulation at another body part location, or altering the way somebody turns on their voice, for example, or moves a body part. The other signature feature to dystonia is that it has task specificity. The spasms for the affected musculature come on under a specific task. And it is often idiopathic, although it can be familial. It could also be sporadic. And for those who have dystonia and tremor in differing body parts, tremor that is of a dystonic nature, if you see tremor in a body part you know has dystonia, then you would call it tremor associated with dystonia. So the tremor of dystonia is also anticipated to be subject to the same kind of clinic features as dystonia itself. So now let's talk about vocal tremor. Vocal tremor is a neurologic voice disorder. It is characterized by a nearly rhythmic modulation perceptually of pitch and loudness, and often is a voice characteristic we hear in those diagnosed with essential tremor, Parkinson's disease, and also those who have dystonia. And here is an example of somebody who has a vocal tremor that I'll play the audio of. And I've got an acoustic plot here that you can see on the top of that. I don't know if you can see my cursor, but it says raw audio, and you can appreciate, if you can see this, that there's sort of this nearly rhythmic pattern of an expansion and a compression of that signal. And down below, the green line is plotting out sound pressure level modulation associated with that tremor voice. And then the FO represents in the blue the plot of fundamental frequency modulation. And in this case, they are not necessarily in phase. So sound pressure level and fundamental frequency seem to be going almost opposite directions in this particular person's voice. Vocal tremor is not always evident during somebody's conversational speaking. And so if we want to test for vocal tremor, we best hear it when we ask an individual to sustain phonation. And what we will hear is this modulation that you just perceived of pitch and loudness, but we can further measure that. So acoustically, when we record these individuals, we can measure the rate of that modulation, which has been reported in the literature to range between 3 and 12 hertz of that repeating modulatory pattern, and then the extent or magnitude of modulation. And again, in the literature, it's been reported to be about 20 to 30% range of modulation. Individuals affected with vocal tremor tend to speak significantly slower in rate than normal speakers. And in one publication, that was reported as speaking at 3 syllables per second instead of the typical 5 syllables per second. And some individuals will report to you that when they drink alcohol, they notice their symptoms improve. This does depend on the etiology of the tremor, however. Now, this is where it gets tricky. For those who have more severe vocal tremor, they may be affected so that the structures with tremor oscillate significantly, resulting in disruptions to the vocal signal. When the tremor is affecting the laryngeal structures, this can result in voice stoppages or breathy breaks, depending on the synergy between the movement of the vocal folds and the tremor affecting those structures. What can then result are these voice stoppages that break up the voice, and that can be confused with laryngeal dystonia. What is important to listen for is the perception of the rhythmicity of that, and also to examine the upper airway structures to observe oscillation affecting the structures involved. So here's an image taken from a publication showing the upper aerodigestive tract. So here's the mouth, the oral cavity, the nasal passageway, the throat, and then on down to the lungs. Basically, the voice requires respiration, phonation, and articulation in order for us to speak. And if any of the structures that help us also breathe, produce our voice, or produce speech sounds also have tremor, the oscillation of those structures will manifest in our speaking signal. And so what we perceive as vocal tremor is really an acoustic consequence of tremor affecting speech structures in the apparatus producing speech. and it results in this involuntary rhythmic modulation of the voice, very different than, say, vibrato, which singers commonly like to use for an aesthetically pleasing singing voice. Now, as far as vocal tremor classification, nothing has really come out since 2005. The last publication of consensus was done isolated to otolaryngology by the Neurolaryngology Committee of the Academy of Otolaryngology. So the Barati et al. Publication from 2005 commented on vocal tremor, and they reached a sort of consensus of a small group of co-authors on how that would look. So here is their classification of vocal tremor. They classified essential voice tremor as an idiopathic action tremor, meaning muscle has to contract, as part of essential tremor. They also, in this case, included individuals who are not diagnosed with essential tremor but have an isolated vocal tremor, and characterized that essential voice tremor is signature by muscles of the larynx, pharynx, palate, and other articulators and respiratory musculature exhibiting a tremor. And it's not task specific. It occurs during phonation and respiration when you test. This is in contrast to dystonic tremor, where predominantly that tremor is evident in the larynx, and it is only observed to occur during speech production, not during respiration, so task specific. Then also the sensory tricks may happen, and this is associated in this case with placement of the nasoendoscope as what the otolaryngologist would use for testing. In this publication, they also identified Parkinsonian tremor as associated with vertical laryngeal movement in people who were diagnosed with idiopathic Parkinson's disease. However, to date, we really don't have any systematic assessment of classifying individuals who present with vocal tremor. What do we need in order to do that? We need to adopt what the movement disorder specialists have used to classify tremor in the limbs. And that would include noting in our medical history the age of onset of the tremor to the limbs, the head, and the voice specifically. We would also need to know if onset was associated with use of specific drugs or exposure to toxins, and to also indicate when that tremor changes in severity, like during the use of sensory tricks or consuming alcohol, whether the tremor symptoms progressed over time, noting family history or other forms of tremor in the family history for voice versus limbs, and signs of systemic illness that may point to a possible etiology of the tremor, as well as other neurologic signs, including mild memory impairment, tandem gait or subtle body posturing, signature of dystonia. In order to really achieve all of those goals, we really need to partner between inter and multidisciplinary team members. In other words, we need all the specialists who know how to assess all of those things to work together. That would include speech-language pathologists who are really most skilled at assessing voice and speech patterns and function relative to speech context as well as non-speech context. We also need otolaryngologists who are expert at laryngology, because they're the ones who know how to assess the upper airway pathology for medical diagnosis of pathologic contributions of aerodigestive tract disorders. They have the special tools and often partner together with speech-language pathology experts in voice to do these kinds of assessments. We also need to more commonly work with movement disorder specialists who are the experts at assessment and classification of movement disorders. Without knowing what to classify movement disorders affecting the limbs as, we are missing a big piece of information that informs the precision of our own diagnoses of the upper aerodigestive tract. And the neurologists do not have access to the same kind of imaging opportunities that expert speech-language pathologists and laryngologists have. So together we need to partner, and together as team members, we all can help improve patient education counseling and offering the range of resources necessary for the best treatment planning. The one big barrier right now is patient access to experts. Within speech-language pathology, there are over 200,000 ASHA members, and only about 1% of ASHA members identify with specialty interest in the area of voice and upper airway disorders. Less than 6% of speech-language pathologists work in adult-based healthcare settings where those with vocal tremor and laryngeal dystonia are likely to venture. So accessing experts in speech-language pathology, that alone is a barrier. Next, laryngologists. Only about 2% of the Academy of Otolaryngologists are comprised of laryngologists, and this is based on membership in the American Laryngologic Association. And then finally, movement disorder specialists. There are only 3 listed on the National Spasmodic Dysphonia Association website. So we have a real problem here that those who are expert are far and few between for being available to the consumers who need them, much less being able to partner those experts together as a team. So that's one of the problems we need to really work on. But let's say you have an ideal team. So I get to enjoy working in an environment where we do have that team. What should that evaluation look like? If we really want to do this right, we need to do a really good case history. We need to do a speech motor assessment that does a thorough evaluation of cranial nerve evaluation for context. So speech versus non-speech, respiration. We need to also do a systematic speech assessment that enables us to discern better auditory perceptual features that might be misleading and lead us to a misdiagnosis, and a systematic nasoendoscopic exam so we can see what the structures of the upper airway at least are doing associated with the signal we hear out as the voice or speech production. And then acoustic analysis ends up being quite useful for detecting vocal tremor and measuring it. So in those who either we perceive tremor or even if we don't, acoustic recordings enable us to really determine if there's a tremor there and help us to measure what that tremor looks like. So for the interest of time, I'm going to focus really on auditory perceptual features and nasoendoscopic exam in this talk because they are the most common aspects outside of the cranial nerve assessment that will be done across team members. And just want to hone in on what are the clinical features of vocal tremor we should be noting systematically in order to classify vocal tremor by tremor type. And that would include making sure we get a clear documentation of all of the structures affected with tremor, not just the speech structures, but also the structures of the limbs. We need to note symmetry and also the condition under which we see that tremor occur, in addition to the body distribution. We need to therefore assess the voice under quiet breathing, which is not assessing the voice so much, but really looking at posturing of the upper airway. Technically, the only speech structure that really can be supported against gravity is our jaw, which indirectly then supports our tongue. But all of the upper airway is posturing for breathing, for respiration. So technically, none of the upper aerodigestive tract features include rest tremor. They just can't, not in an awake individual anyway. So we just have to keep that in mind when we're testing. But task specificity is really something missing from our current assessment regularity. So we do need to compare and contrast what we observe with the tremor during quiet breathing for contrast to speech production so we can determine if there's task specificity. And then to the degree we can measure rate and extent, but at this point, we really are only able to do that using our acoustic signals. And the output from our voice is really a summation of the structures producing speech that have tremor. And so it may or may not be accurate for representing individual body parts contributing to the vocal tremor when we measure acoustically, but it does at least give us a measure of the acoustic signal that we perceive tremor in. And so what you see here is a plot of fundamental frequencies, sound pressure level, and then also what we call formants, spectral energy measures that we can make of formants 1 and 2 that let us know if the tremor is isolated to the larynx or also affecting other speech structures in our vocal tract. What are we listening for? Well, differentially, what we should be listening for to differentiate between vocal tremor and those with laryngeal dystonia is that vocal tremor should present with rhythmic modulation of pitch and loudness during sustained phonation. If we hear voice stoppages or breathy breaks, and it's not due to laryngeal dystonia, they will occur in a fairly rhythmic way that's not clearly phoneme specific, meaning those with adductor laryngeal dystonia tend to produce strained, strangled quality or voice stoppages associated with voiced phonemes. Those with abductor laryngeal dystonia tend to produce these breathy breaks or changes in their voice quality associated with the production of voiceless phonemes. One caveat here is vocal tremor is only detectable when we sustain phonation, and so arguably we may perceive vocal tremor to be phoneme specific to voiced phonemes, particularly voiced phonemes we prolong. So the task specificity is going to be incredibly important for us to test for distinguishing tremor of a dystonic type from tremor of another classification, and those who have laryngeal dystonia with either a co-occurring essential tremor or a laryngeal type of dystonic tremor affecting their voice. The other aspect to the dystonias is that you should also observe that in almost 50% or more of those individuals, you may see that sensory tricks alter the severity of their symptomatology. Specifically, the otolaryngologists report anecdotally that they notice symptoms from conversation to change when they place the scope in the nasal passage. It can often help reduce the severity of those symptoms. And we hope to report in on a systematic study we're finishing up now on data collection about just that, the contribution of sensory tricks in changing the symptomatology of those with laryngeal dystonia compared to vocal tremor of the essential type. And we hope we'll be able to give some information about whether that does make a difference or not. But for vocal tremor, we do need to be careful that we try to classify whether when there's a co-occurring tremor with laryngeal dystonia, characterizing task specificity will help determine if it's of the essential or dystonic type. So let's play a couple of examples just to illustrate this. So let's listen, first of all, to somebody who has classic symptoms of adductor type laryngeal dystonia. Then I will contrast it with somebody who has abductor type laryngeal dystonia. And then we'll listen to somebody who has vocal tremor to see if you can distinguish the features we just described.
Take the shape of a long round arch with its path high above, and it takes its two ends beyond the horizon.
Okay, and now I've got a second contrast is somebody with abductor type laryngeal dystonia.
He's take the shape of a long round arch with its path high above and its two ends apparently beyond the horizon.
So hopefully what you could hear with these two individuals, they were very clear-cut adductor type, strained, strangled voice quality with voice stoppages versus abductor breaks, and both sounded fairly normal during sustained phonation. Now let's listen to our individual with vocal tremor. And connected speech.
The blue spot is on the key again. How hard did he hit him? We were away a year ago. We eat eggs every Easter. My mama makes lemon muffins. Peter will keep at the peak.
So for this individual, you can definitely hear voice stoppages in this person, but hopefully what you were able to perceive is that There was a clear tremor on sustained phonation, and during connected speech, the voice stoppages seemed kind of rhythmic. Now, if we just stopped there and we didn't go any further, we might lose an opportunity to observe that the voice stoppages in this vocal tremor patient occurred associated with oscillation of the structures that were affected by tremor. They were not spasmodic, or they were phoneme specific to a voice phoneme, but they were due to tremor, not spasmodic dysphonia. So let's move forward and talk about how do we go through this assessment to be more clear about the distinction of these individuals. First, let's start with our cranial nerve tremor assessment. And what we want to first be able to map out is documenting when we see tremor, where is it occurring? So we should be looking at all of the speech structures, not just using nasoendoscopy, but also observing from external of the person, noting the jaw, the face, the lips, the respiratory system, the hands also will be important to note, although not part of the cranial nerve assessment. But we want to note the distribution of that tremor across all the body parts. Then we also want to indicate the presence or absence of tremor by task. Did it occur just at rest at rest with the jaws, really just posturing, opening the mouth or a kinetic movement of some kind, or during speech tasks? We also want to note symmetry. Is it only present on the right or left side? Or do we see bilateral involvement? So noting symmetry can also be quite informative. Now, once we finish our cranial nerve assessment, we want to do a systematic auditory perceptual evaluation. In our clinic, we also simultaneously record the acoustic recording for analysis. Our systematic testing should include sustained phonation of vowels on E across pitch and loudness levels. We also want to test high pitch speech production tasks, which often will take somebody with laryngeal dystonia who sounds abnormal at comfortable pitch and loudness when they talk, but they may sound more normal when they're trying to speak in falsetto. Having the individual shout phrases to see if we hear consistency of strained, strangled quality regardless. And for those who yell, those who have adductor type spasmodic dysphonia may actually struggle a bit more with shouting their phrases, wait for me. Those with tremor also may sound better when they shout their phrases. Those with abductor type spasmodic dysphonia almost always sound better when they shout their phrases. And then counting between 60 to 70 and 80 to 90. The 60 to 70 has voiceless phonemes as a dominant sound production. And from 80 to 90, it's almost all voiced phonemes. And then comparing imitation of sentences to reading of sentences. And in particular, we like to compare and contrast sentences with phonemes that are voiced versus those that are voiceless as our way of distinguishing laryngeal dystonia symptomatology. There are some sentences that have been published by Ludlow et al. In 2008 that are often utilized for this kind of testing. And here, the underline marks indicate places that they found frequent voice breaks in those with laryngeal dystonia and are distinctive for phoneme specificity of adductor type or voice phonemes versus abductor type sentences or voiceless phonemes, and then also whispering those sentences to see if there's a change in symptomatology. Often in those with vocal tremor, you may actually hear modulation if they are severely affected, regardless of whether they're using their voice or not, depending on the structures that present with tremor. Now let's compare two individuals and let's see what your perception of their vocal tremor severity is between sustained phonation and connected speech. Here's case number one. And connected speech. Well, actually, let me play case two so you can hear how they compare on sustained phonation. 3 to 5 seconds. Okay. And now do the same thing with the sound E. Very nice. Now what So both of these individuals, to my ear, sound moderate to severe on the degree of severity of tremor on sustained phonation. Now let's contrast them during connected speech.
The blue spot is on the key again. How hard did he hit him? Where we were away a year ago. We eat eggs every Easter. My mom makes lemon muffins. Peter will keep at the peak.
And here is our second case in connected speech.
The blue spot is on the key again. How hard did he hit him? We were away a year ago. We eat eggs every Easter. My mama makes lemon muffins. Peter will keep at the peak.
So hopefully you could appreciate that there was quite a difference in severity between sustained phonation condition and connected speech. In case one, I would say that was somebody who probably is moderately severely impacted because I can hear the tremor even during connected speech. But case two was a lot less evident during connected speech. So I'd say mild to moderately affected. So we use the comparison and contrast between sustained phonation and connected speech to inform how severe the vocal tremor is by the degree to which it affects their ability to speak in connected speech. Now, the last part of that's important for observing body distribution and severity and condition of tremor is nasoendoscopic exam. And again, for differential diagnosis between laryngeal dystonia and vocal tremor that's not of a dystonic type, it's very important not to use topical anesthesia or minimize its use isolated primarily to the entry of the scope into the nasal passageway, because already the presence of the scope itself could offer a sensory trick that alters severity of symptomatology once put in place. This also is the reason that we need to do our speech exam under a with and a without scope in place condition, so that you can note any differences in speech disorder severity under those two conditions. Also, while doing the assessment, you want to include an evaluation of laryngeal function of vegetative activities like respiratory, breathing, cough, throat clear, and whistling. And during your assessment, it's important to observe the presence, location, and context or condition of the observation of tremor. This means observing with that scope in place whether the soft palate or velopharynx exhibits tremor and under what conditions, speech or non-speech, the pharyngeal structures, the base of tongue, the larynx, both the intrinsic musculature of the larynx and then also the muscles that affect the vertical position of the larynx. And then what speech tasks, connected speech versus connected sustained phonation. And that's why nasoendoscopic examination is preferred, so that you can compare sustained phonation to connected speech. With a rigid scope passed transorally, you would not be able to test connected speech. And then also making sure you get at least 4 cycles of respiration, so assessment of tremor, presence or absence during breathing can be assessed, and perhaps noting the phase of breathing during which you observe it. Typically, we observe it during the adductory phase as the vocal folds adduct towards each other, which is often done on expiration. And then with that assessment, you can round out your cranial nerve exam to include body distribution, symmetry, and condition, and then noting musculature that is implicated by testing pitch and loudness. So here's a case example of essential tremor illustrating a nasoendoscopic exam. This is the same individual I played to earlier with the audio signal, who was referred to us with a diagnosis of spasmodic dysphonia. And here's what we saw with the nasoendoscopic exam. Good. And now E at a high pitch. And E at a low pitch. Okay. Okay, now
The blue spot is on the key again.
we eat eggs every Easter.
We eat eggs every Easter.
Peter will keep at the peak.
Peter will keep.
So hopefully what you could observe in this individual was that her soft palate exhibited a tremor both during speech and non-speech. Her base of tongue was observed to oscillate even during quiet breathing while waiting for instructions on the next speech task. Her pharynx and her larynx were also involved. And interestingly, this was somebody who had just been treated with Botox 3 weeks earlier. Her larynx did get injected, but because all of those other structures were so involved, she really didn't benefit from the Botox because of the degree of severity of tremor affecting other structures that still contributed to her symptoms that we perceived as voice stoppages, although rhythmically so. And then here is an acoustic plot of this individual during sustained phonation. So you can appreciate she's got in green that sound pressure level modulation that's occurring is associated, when we acquire that during nasoendoscopic exam, it's associated with abduction and adduction of the vocal folds. But also the vocal folds are overclosing, resulting in voice stoppages. And you can appreciate that that fundamental frequency plot in blue breaks out because of the voice stoppages. Let me play that one more time. Yeah, so the is resulting in some voice, but breaks in voice tracking in our acoustic signal. So you can partner your nasoendoscopic exam with an acoustic recording to see if your findings in the acoustic signal match up with what you're observing with the movement of the structures and the auditory perceptual impressions of symptoms. So we just have a publication out hot off the press in the Laryngoscope's investigative otolaryngology. This was an invited paper and reports on the outcomes of our exploration just based on electronic medical review of how clinical documentation of features of those with vocal tremor might help us map out and classify the range of individuals we see clinically. And we learned a lot from this activity. First, let me start out with the last point here, which is we took all comers in the University of Utah healthcare system, regardless of where they were seen. We just wanted to extract records that indicated somebody was diagnosed with vocal tremor. So anywhere in their electronic medical record that they are documented with vocal tremor, we took those individuals, and that enabled us to study records from movement disorder specialists, otolaryngologists, and speech language pathologists. Thereafter, we classified based on our ability to extract documentation of the clinical features necessary in order to classify a tremor. Only in this case, we were only taking individuals who were documented with vocal tremor, and we were hopeful that we could use the clinical features to classify them. And we found that systematic testing for task specificity was not commonly done by otolaryngologists and speech language pathologists. And so a lot of the conclusions that came out of our study were that we had an awful lot of missing data because it wasn't a lot of information necessary to classify was not documented. And so distinguishing between those with essential tremor, isolated vocal tremor, and Parkinson's disease and dystonia really made it hard because we had so much missing data that comparison between groups was not possible. So what we ended up doing is a descriptive study characterizing those that we had enough information we could either classify them based on what was in the electronic medical record or based on definitive comorbidity. And interestingly, we found that isolated vocal tremor, meaning individuals who presented with vocal tremor but had no other indication of tremor in any other body part or other comorbidities, looked different than those who had essential tremor plus vocal tremor. So although I do have a publication taking issue with splitting out isolated vocal tremor from essential vocal tremor in our 2018 classification on tremor. It turns out the movement disorder specialists are correct. Isolated vocal tremor exhibited an older age of onset, predominantly female, and did not tend to exhibit spread to the limbs of tremor, whereas those with essential tremor and vocal tremor equally presented males and females, just like essential tremor does. And there was a pretty frequent occurrence of spread to affect the voice, and it was very much like we think. So in our clinical classification of features of vocal tremor, essential tremor was characterized as individuals who had an action tremor of the bilateral upper limbs for a duration of 3 years or more, no other presence of Parkinsonianism, ataxia, or dystonia. But essential vocal tremor did match with exhibiting or having documentation of multiple upper airway structures being involved and not being task specific. Isolated vocal tremor also looked like this, although their demographics differed. Those who had dystonia and tremor did show task specificity. And so for this, we defined it as those who had irregular tremor observed during volitional activities that could be altered or reduced with sensory tricks, and those who had the dystonic vocal tremor, in other words, co-occurring with the diagnosis of laryngeal dystonia of the adductor or abductor type. They predominantly exhibited documentation of the larynx being involved and not really anything else. The task specificity was not very well documented, but in those we could discern it. It had appeared that the nasoendoscopic exam observed speech production and sustained phonation as the tasks under which it was the tremor occurred. And the other diagnoses tended to be laryngeal dystonia, but in some cases cervical dystonia was also acceptable. So those were some of the findings that we were able to report on. Now, let's go beyond assessment into therapy. And I would like to just say that I'm going to transition into treatment by saying that voice therapy, when you're uncertain about a case, can also be used as a diagnostic tool. So for somebody who may have an overlay of muscle tension dysphonia, we should theoretically be able to offload that excessive throat tension through voice therapy techniques and make that consistently occur with strategies that we can therapeutically teach our patient. Laryngeal dystonia is sometimes hidden. The actual specific features we need to classify as adductor or abductor often can be released by offloading that tension and muscle tension dysphonia. But furthermore, we can also help make more clear whether it's an actual underlying tremor as well. So therapeutically and diagnostically, voice therapy can be used to reduce the excessive muscle tension that makes it difficult to make a conclusive medical impression for treatment planning. But it's also not a lost cause for benefit. Ultimately, even if it doesn't take care of all the problems associated with the voice, it teaches communication strategies, and all of our patients benefit from that. Learning how to handle difficult speaking situations and strategies to optimize managing those situations is still beneficial to the patient. So most areas of speech language pathology don't cure the problem they're managing. They teach strategies for managing it, and that's what we can do here. But for vocal tremor, speech treatment also can be quite useful for helping to offload excessive upper airway muscle contraction that only amplifies the presence of tremor in the affected structures. We can teach strategies for reducing voicing duration. Vocal tremor itself is a slow modulation rate, and so we can break up voice duration and take away the ability for the listener to hear the tremor in those individuals capable of doing so. And then finally, manipulating prosodic patterns like altering pitch and loudness can also be used to either entrain the tremor to your benefit as a method of using it for your prosodic intention, or by disguising it by using your prosody to either go up or down in pitch to make the tremor less severe. So one thing we want during our assessment is to note tremor characteristics. We need to know if the tremor is worse during sustained versus connected speech. If you see that somebody has a pretty consistent severity of tremor regardless of context, that's important to note. If you don't hear tremor, still analyze the acoustic signal to see if you see any indicator in the acoustic signal of tremor, because sometimes there are subthreshold or subperceptible degrees of tremor that may still be sensed by the individual but not perceived by the listener, and use laryngeal imaging to confirm the structures that are involved. And then we also like to test whether somebody can voluntarily modify the duration of voicing duration to determine if treatment is a good option. So here's an example of a technique used in a prior publication of a undergraduate honors thesis. And this compares individuals prolonging their voice using a legato way of talking versus shortening voicing duration with staccato. So let's listen to the comparison and contrast. Here's legato.
Mama made.
And here is staccato.
Jam. Mama.
Here's legato, the same person.
Jam. Harry had
and staccato.
Head of hair. Harry.
So this is the individual who previously I categorized as being moderate to severe because he had pretty consistent involvement of tremor in his connected speech. But here we had him do a staccato manipulation and he was able to voluntarily reduce or shorten the voicing duration. That meant that he could potentially benefit from voice therapy, even though we considered him to be kind of severe. So over a series of individuals, we've not done a systematic lab-based test of treatment effectiveness, but we are hoping to get that work underway. But we have spent time just determining who does it work with and what are critical elements. And here's what we found. The best responders are those who do have a mild to moderate vocal tremor. And the optimal, most critical program elements to the speech program are training respiratory phonatory coordination to offload that upper airway muscle contraction to make it less tense. Most individuals come to us trying to control that tremor. We want them to not try to control the tremor using increased use of the respiratory system, and then also to train shortened voicing duration when talking so as not to allow the opportunity for modulation of the voice that listeners can then detect vocal tremor. We want to reduce that opportunity. Thereafter, we can also kind of polish up speaking and make it more their style. In more severe individuals, we've found inserting pauses where they can replenish air supply as incredibly beneficial for optimizing, making sure we don't have a sort of drift into increased muscle contraction of the upper airway, and breaking up phrases in order to help improve shortening voicing duration. In some more severe individuals, increasing breathiness during speaking is helpful. It kind of creates this pillow effect between the vocal folds so that if the larynx is oscillating quite a bit, inducing breathiness helps prevent voice stoppages, but also is a way of lessening muscle contraction as well. And then modification of intonation patterns to use prosody to help redirect that tremor in a positive way to help with intonation patterns. We usually need to treat individuals for 6 to 8 treatment sessions because the behavior modification aspect, we're taking a long-standing pattern of talking and we're modifying it on purpose. And to date, we've really just focused on 1 session per week for up to an hour of work because that is what we can offer in our clinic. But we are going to try to experiment with what happens if we do block treatment versus this interval of treatment. But critical to success is the implementation of daily home practice by the individual. It doesn't help if they only come to therapy and do this work. They have to do it every day where they use their voice. And we find that we actually can get measurable outcomes. So sustained phonation acoustic measures of rate and extent of tremor ends up being useful to measure, but really more informative is the ability to which a listener can detect the presence of vocal tremor during connected speech, and the patient's self-report of outcomes ends up being quite useful. We do need to consider the severity of the tremor over time, structures affected by the tremor and the degree to which they might be structures that end up perturbing progress rather than supporting progress, individual speaking patterns that make the tremor worse or better, and the individual's motivation. Strategies may not automatize, if that's a word. The person has to be quite motivated to use these strategies. And even if they don't become automatic, the person can call on those strategies in situations that are otherwise more difficult and purposefully make change. The person has to be able to attend treatment sessions, and we don't know right now whether there's a difference between outcomes with virtual versus in-person sessions, but that's another factor to consider. And we actually do this a lot as a supplement to Botox. So this doesn't preclude use of Botox. This can complement Botox and help prolong the benefit in between treatments. So in summary, the clinical features of vocal tremor are poorly characterized in our literature, and they do require that we adopt a better systematic testing approach across multiple disciplines. We do need to partner with movement disorder specialists because they do bring the other information from the limbs to help inform what's going on in the speech structures and help to round out a more full body picture, literally, of the individual who's affected. We need to do assessment in a very systematic way using updated tremor classification criteria, and to do it in a way that allows us to map body distribution, symmetry, rate, and progression over time, and hopefully bring to light the features that help us differentiate between those who have dystonia etiologies or dystonia classification of tremor versus other neurologic syndromes. In the right hands, speech treatment can benefit those with vocal tremor, but again, there is a patient access barrier to speech language pathologists who are actually expert at voice. So I hope this has been informative. Here are my references. And I hope that this talk has been helpful in clarifying updates in our thinking about vocal tremor and laryngeal dystonia.